Hello, this is Dr. Carrie Bedient with Fertility Docs Uncensored. I'm at the Fertility Center of Las Vegas, and I am joined by my staggeringly, sensationally splendid co-hosts, Dr.
Wow.
Hudson from Texas Fertility Center
Thank you, Carrie.
and Dr. Abby Eblen from Nashville Fertility Center.
Very nice, Carrie. I feel so much more important now.
You should.
You are important.
You were just asked to give a keynote at, is it your...
It's my sorority alumni group. So apparently, and this hasn't been a routine thing, but last year we had a group of people that gathered, and this year is the 66th anniversary of the sorority being on our campus. And so I actually was not planning to go. I went last year. And so I was already put myself on call that weekend, and I just got an email, which was really nice. And they were very nice to ask me to do it, but they asked me to be the keynote speaker. And when you put that word keynote there, it makes me a lot more nervous than if it was just, could you speak, And so anyway, so I'm trying to like contemplate what I want to talk about. And the only thing they said is it just needs to be inspiring. And so I thought maybe you guys could help me come up with some inspiring topic to talk about, or topics.
So this is you said 66th anniversary of it being on your guys' campus.
Yeah, so it'll be like sorority girls all the way up to 60-something-year-olds, I'm guessing. So a wide range of women in the group.
Fertility preservation.
Yeah. I think that would be a good thing. I might get some people listening to our podcast, with that. But I probably need to like talk about something a little bit more encompassing for like the whole group, though.
So I think you should do, and granted, this is heavily influenced by me just having a big birthday, but
Yeah.
I think you should talk about the delightful FU factor that comes with age.
Oh, there you go.
Of women who are in college, who are, even when they're confident and smart and have it all together,
Yeah.
there is a difference. Like when I think about my 20th birthday, my 30th birthday, and my 40th birthday, like the filter has come off progressively more.
Did you ever really have that much of a filter,
I was gonna
Carrie?
say, was the filter there for you?
Oh, total. Oh, yes. And I am still so filtered. Y'all have no idea.
We see a different side of you, Carrie. Is that what you're saying?
No, I'm saying you see one of the more unfiltered sides of me.
Okay,
Like
good.
my husband and my girlfriends who are here in town who have more relaxed exposure rather than with a microphone right in front of me see and even more unfiltered. Like you put 2 glasses of wine in me and the filter,
there's no filter.
There is no filter. So like you guys are kind
personally
of
love the completely unfiltered Carrie, so I just want to let you know
that. I love Carrie the way I know Carrie. So
I wait till we have the next meeting together where it will come out more and more the longer I know you. But I think you should talk about how things change throughout the years and maybe how supportive that group of women is in developing what will ultimately become the unfiltered version of all these women who go through it.
Oh,
I like it.
Good thoughts. Good thoughts. I think this would fit right into kind of what I was sort of thinking is like life lessons that I've learned, some good ones and some bad ones, some funny ones. And just recently, unfortunately, lost really close friends that I knew from the sorority. And so one of those life lessons is, reach out to your friends, old and new, because, you don't know when they're not going to be around anymore. So, but yeah, I could fit that right into like, one of the life lessons I've learned as I've gotten older, what I thought mattered in my 20s probably really doesn't matter that much anymore. And you should, own that.
I like that.
Definitely.
Very good.
All right. So on a totally different note than empowering women as they age, let's talk about poor quality swimmers and male factor infertility.
We got to do a question though first.
We do. But the important thing is remember that 40% of all couples with infertility have some contributing male component. So even though we don't talk about it quite as much as we do all the lady parts,
40% of the time,
ladies tend to be a little bit more complicated. The swimmers are important, and we need those swimmers to meet up with the eggs. So we want to make sure they have their due course in our podcast.
All right. So what questions do you have for us today, Susan?
All right. So our first question is, I've heard y'all mention low sperm count, but what about motility and morphology? My husband has a normal high count, but the morphology and motility are low, as is his testosterone. How do these factors affect fertility, and what are best options for overcoming them? That's a good one.
That is
So
a
that
good
leads
one.
right into what we're going to talk about. So should we just talk and then we can answer that question along the way?
Let's do it. So what do you think about a normal sperm count, but low morphology and low motility?
Well, I think that when you're looking at motility and count, looking at those numbers together really is what's important for the most part, because
Mhm.
if you have a really high count and your motility is a little bit low, but the average number kind of between those two ends up still being a good enough number, that's what matters. Okay. I mean, we love to have more is better, but I think that looking at those numbers in combination. Morphology, yeah, okay, this is the way I feel about morphology, and y'all can tell me what you think afterwards. So, about every 10 years in my professional experience, there's talk about just getting rid of morphology as something on
Right.
a semen analysis.
Yeah.
And the fact that we keep on revisiting this every 10 years pretty much says to me it probably isn't as important as we all think it is. And so it's something we pay attention to, but it's nothing that I would ever make a major decision on. And so that's kind of where I fall into kind of the meaningfulness of those numbers. What do y'all think?
Well, I think with morphology, I mean, the thing about it, and we've talked about this before, it's sort of a subjective look at the sperm, like are they shaped correctly, the head too big, the tail too crooked. And what we really don't know is how clinically significant that is. You know, I tend to believe if I see somebody that has 0% normal morphology, I tend to kind of pay attention to that. But I'm like you, Susan, I wouldn't change and do something major. And by major, I mean the only way that we can get the sperm closer to the egg or in the egg is to do IVF. I certainly would make a decision to do IVF, at least not immediately based on one morphology. You know, we know that what happened 3 months ago with your partner may have made a difference with the morphology, and maybe over time that might get better. But I certainly would think it would be reasonable to try at least some office procedures like intrauterine insemination just to see if we could get the sperm closer to where it needed to be and really determine if the morphology really made a difference. And one last thing I'll say on morphology too, you know, if a guy is sitting in front of me and he has 2 or 3 kids and his morphology is bad, I'm not so worried about that. That tells me that's my answer. That tells me his morphology really doesn't make a difference if he's had children before and that the sperm has been able to get where it needed to go. What do you think, Carrie?
I mean, I think it all kind of plays in. There was a study that showed the more numbers of affected kind of categories in a sperm analysis, the higher the likelihood that there was a male factor contributing. And so if you had somebody who had looking at their motility, morphology, and concentration, if someone had just one thing off, that was a much lower percentage of male factor impact than if they had two or than if they had all three things off. And
That
so
makes
I think
sense.
I think it kind of plays into
Yeah.
that. I mean, I agree. I'm not going to make or break decision on no morphology. If I have someone who has zero, then I might say like, hey, let's talk about IVF so we can do ICSI. But even then, if the concentration of motility is really good, I'm not averse to doing a couple of IUIs because if it works, fabulous. And if it
Yeah.
doesn't, then we go back to doing what we were going to do anyway. Um, so yeah, that's kind of where I come down on it.
And then as to things that we can do to affect either motility or morphology.
Stop smoking, all of
Stop
it.
drinking excessively.
Stop smoking marijuana specifically.
Stop putting your testicles in really hot water, like hot baths or hot spas or those types of things. There's not great data for it, but it does kind of seem like you're parboiling your sperm, and that's probably not helpful. I don't care about, a couple minutes here and there. Showers are fine,
Heat.
whatever. Don't
Chronic
stop
heat's
bathing.
not good.
And
Yeah, and also to that end, don't put your computer in your lap if you're a guy and work. That can heat your testes. Or crazy things I've seen before too. I've seen a guy that was training for a triathlon. He was biking a bunch, and the friction from biking heated up his testes, and you could just see over time his count and motility just went. "Uh."
Yeah.
And if you are excessively overweight, and I'm not talking about you have an extra 10 pounds, I'm talking about you have an extra 100 pounds. If you are excessively overweight, lose weight.
Absolutely, because that increases estrogen, and those men tend to have lower testosterone as well. The other thing, kind of weird things out there, people that have exposure to chemicals and things I'm specifically thinking about is people who are like embalmers. They're exposed to a lot of toxic chemicals. People who work in dry cleaning, that sort of thing. Firefighters, chemicals can make a difference for guys as well.
I've also seen some of my military folks who are exposed to burn pits.
Oh yeah, yeah.
I've never seen any published data on it, but it just feels like I see that more often in those guys.
Well, we know with women too, if they're exposed to chemicals in the air, like some of our patients that are from different countries where there's really high exposure to things in the air, particulate matter in the air, smog, that can have make a difference for women. I'm sure it can for men too.
Yeah. All right. What's our next question, Susan?
Our next one is, how does nicotine, specifically in my situation with nicotine pouches that my male partner takes, impacts the mobility of sperm?
I mean, nicotine's probably not good for anybody. I think maybe a patch might be better than smoking because smoking exposes you and your partner to a lot of other chemicals. I don't know that we really know that for sure.
Pouches. Aren't pouches like
pouches.
dip things?
Oh yeah, probably dip. Yeah.
So you're getting pretty intense nicotine levels when you're essentially ingesting it sublingually. And so we know that nicotine does, impair the development of healthy sperm, and it can make a big impact. And the nice thing, really the biggest amazing thing about male factor is you get new sperm every 72 days. So the things that we're talking about that you can change, yes, it can take a little time for it to have an impact, but you have the unique ability, much less than your potential female partner does, to make these lifestyle changes and have a significant impact on your fertility in 3 months from now.
Yeah, go ahead, Carrie.
I was going to say there was a rat study that looked at just nicotine, not carcinogens like you would find in an actual cigarette or dipping or whatever. And just the straight nicotine exposure dropped both motility and count in each of those. So, I think it's entirely possible that will apply to male humans as well as male rats. And so something to kind of think about.
So when somebody dips tobacco, they're exposed to nicotine. Are they exposed to other carcinogens in that, or is it just mainly nicotine? I don't know.
No, I think it's all the carcinogens that are in tobacco as well, because it's not the isolated compound that you get.
Yeah,
like in a nicotine patch.
Yeah, gotcha.
Yeah, it's all the
still tobacco.
Yeah, I just know when we send patients to our fertility urologist, they're like, whatever your bad habit is, you need to stop. So smoking, eating too much, drinking too much, all those sorts of things, it's only going to improve most likely if you change your bad habits.
Some of the data is kind of inconsistent when you do look at the human studies. But it's convincing enough that it's probably not helping you. And if you think about it, the way that it's expunged from the body is through the male reproductive tract. Like your urine takes part of the same pathway that your sperm takes coming out. So any bad news that's left in there, the sperm are going to pick up on their way out. So,
well, we know women that are smokers have higher risk of vulvar cancer and things like that for the same reason. It's in their urine and it comes out on their vulva, and they're chronically exposed to that.
The number one reason for bladder cancer is nicotine exposure.
Yeah, so it can't be good for you.
All right. What's next?
Right. Our next one, my husband and I have been trying for kids since July of 2021. And in February, we found out he has a very low sperm count. Both sperm samples were under 10. We've seen a urologist and he is having surgery done. I've had my IVF consultation. We will be beginning in summer of 2022. My husband is 26 and I am 25. My test results have come back normal and I have 25 follicles on my left and 30 plus on my right. If everybody was
eggs.
Is there anything my husband or I should be doing now to prepare for IVF? We've almost completely cut out alcohol. have been eating a healthy diet, but always looking for tips on how to set us up for the most successful IVF possible. I love your show and can't thank you enough for all the information you've shared.
So it sounds like they've already cut out a lot of the exposures that we worry about.
Mhm.
There was one study that looked at potential male supplementation that may have a positive impact, things like vitamin C, vitamin E, CoQ10, L-carnitine, and N-acetylcysteine. I think those are the ones that have the most generalized, like taking a supplement and it might have an impact. And
Mhm.
you can go back and listen to some of our supplement episodes to hear the pros and cons about supplements. But I doubt that that's going to hurt. And so I tell a lot of my guys to take it just because it's cheap and
It's not
easy.
going to hurt.
It's not going to hurt. At the worst, it's going to make expensive tea, and at the best, you're going to do something helpful for yourself. Um, so really getting rid of a lot of those exposures, like we talked about, getting sleep, eating healthy, those types of things are beneficial.
One thing she mentioned is that they're going to do IVF. His count's been less than 10 million, but he's also going to have surgery. So
Well, he said it's less than 10, not 10
less than
million.
10. Okay. And he's going to have surgery, and I assume
I'm guessing they're
varicolectomy.
doing a Tessie or
Maybe a
micro Tessie.
Okay. 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 Yeah. I was going to say if he produced sperm, he probably wants to freeze some for backup. But if he only has 10 sperm, then probably microtesting, yeah, is what they're doing.
Yeah. Okay. What's next?
All right, our next one. My husband had a vasectomy reversal last summer. They told us that day that it failed after it only
Oh.
being 4 years old. First of all, have you ever seen anyone get pregnant from the vas deferens healing? Is that possible? Also, why is IVF the only option, not IUI, when he has viable sperm to do a TESA or PESA?
That is a great question. People always ask that, or if they have sperm, husband has frozen sperm, like from cancer treatment a long time ago or something, and they come for fertility treatment, they don't realize that the sperm that's frozen is really a low quantity. Although he may have several vials of sperm, human reproduction tells us that there has to be a certain amount of sperm in order for it to happen the old-fashioned way or to happen by doing IUI. And we've talked about this before, but with intrauterine insemination, it's the numbers kind of vary, but you need somewhere around 8 to 10 million total motile, meaning 8 to 10 million moving sperm in order for it to make it worthwhile for you to have an intrauterine insemination done in the office. And even with that, if you had like 3 vials of sperm, basically your chances at best case scenario, if you're really young and healthy and have a good egg number, best case scenario, your chances would be maybe 8 to 10% in the office if we do IUI. If your husband only has 3 vials of sperm that are frozen, then we don't want to waste one of those with only a 10% chance. Whereas if we do IVF and you get 10 or 15 eggs, you may make 2 or 3 genetically normal embryos and have a really high chance with each one of those embryos in terms of conception. So, if you had a bunch of vials of sperm and they were really good, maybe you might try IUI, but that's really rarely the case. Usually patients that have frozen sperm have to do IVF with ICSI.
Very much a
Agreed.
numbers game, and the extracted sperm counts just they're not high enough, unfortunately.
Yeah.
I don't know that I've ever seen anyone who has been through a reversal with a spontaneous healing. Surgery, reversals, all those procedures generate scar tissue. And when they're trying to do a reversal, they're being very gentle with it in terms of trying to cut out the scarred down portion and rejoin the tubules to open ends. But of course, that's not always possible. And so
You only
generally,
need one, though.
you only need one.
Miracles do happen, but that's what it would be as a miracle.
Yeah.
Well, it sounds like if they were that quick, I mean, I don't know of a urologist that I remember ever saying immediately on the day of surgery it wasn't successful. If they're
There
that
must have been a
adamant,
lot of scarring.
there must have been a lot of scar tissue and they just didn't get the tubes back together at all. I mean, it almost sounds like there wasn't enough good normal tubing to put it back together or something for them to say that on the day of surgery.
Yeah, absolutely. All right, our next one, kind of still on the vasectomy kick here. This is my first round of IVF. We are on this journey because my husband had a vasectomy 15 years ago. He's 37 with 2 children. I'm 33 and never been pregnant. All my tests came back normal. My husband completed a sperm aspiration first, and the sperm was frozen prior to my egg retrieval. At my egg retrieval, they were able to get 18 mature eggs, and they fertilized all the mature eggs, and 8 started to grow on day 1. After the 7 days, only 2 made it to blastocyst, but were rated a D and not viable for pregnancy. We were told bad sperm. Is this a normal side effect of a vasectomy? They used 1 of the 8 vials of sperm. Should we use the rest of the sperm in a second round, or should we look at a fresh retrieval and aspiration for IVF? Oh, that's hard.
That's a hard question.
Yeah.
I mean,
What do
that might be a question for the urologist, and it depends a little bit on how bad the sperm looked. Something tells me it was good enough, though, for them to use it. They didn't have to thaw another vial. So there was sperm there that probably was motile, but if it was just really poor quality, maybe the other vials had poor quality too, and there was no benefit to thawing more. But that might be a question for the urologist if it would be better to do another aspiration at some point.
I do have to say though, I think sometimes, I mean, I would be concerned that this is a situation where it's like, oh, it's post vasectomy sperm. This is a sperm issue. And if you haven't had sperm exposure in prior relationships, this also could be an undiagnosed egg issue as a
Mhm.
possibility.
Yeah.
I mean, we see this quite frequently in our same-sex female patients, in that they come in, they think they're going to get pregnant right away using donor sperm, and after a few rounds, we end up turning to IVF, and it's because unfortunately, infertility in humans is pretty common, and so I would be wanting to really make sure that you had a full evaluation of your ovarian reserve. I mean, obviously you have enough eggs, but quality and quantity are not always the same.
The other thing that sometimes we see, and I see this with a lot with my guys who have frozen sperm, because that's a heavy part of our practice, is that you can have somebody who has a pretty normal count going into the freeze, but when they thaw it, the freeze exposes that the sperm doesn't recover really well. Because normally you would expect, a solid 50% of a frozen sample
Mhm.
to be good once you thaw it. That means you're going to lose roughly 50% or so. And those are not hard numbers, but in general. And I definitely have some guys where their numbers looked great going into the freeze, and then we see them coming out of the freeze and they're just consistently bad. And so the sperm just doesn't weather it quite as well. And so it may be one of those situations where a fresh sample is advantageous, because there is some inherent issue in the sperm that,
Some sperm just don't like processing.
yeah,
Mhm.
yeah, they don't like having to swim through the mazes that we make them swim through. And so they just kind of say, screw you, and go on vacation. What
All
else you
right.
got, Susan?
Okay. Hi there. Love your podcast. Really appreciate all the help you ladies provide. I'm 36, husband's 35, doing IVF because he has non-obstructive azoospermia of unknown cause, normal karyotype, no Y chromosome deletion, not a cystic fibrosis carrier. She also has diminished ovarian reserve, though not primary reason for IVF is required. Husband had a testing in early 2022, froze 3 vials of sperm, just finished our first IVF cycle, antagonist protocol with 375 of follistim, 225 of minipure, 1 mg of dexamethasone, 55 I use omnitrope for the first 8 days, and added in ganirelix starting on day 7, increased ganirelix to twice a day on day 10, and did 10,000 IU pregnal trigger. And threw in a second 10,000 IU pregnal the next day as well.
Wow.
Doctor retrieved 3 eggs, also had a few other follicles that were not mature at retrieval, and all 3 eggs were matured, but none of them fertilized. When I had my follow-up with the RA, she said the lab did not leave any notes regarding issues with egg quality, and she told me she suspects the sperm quality issues most likely contributed to 0 fertilization. They had to do some sort of test to select living sperm, since none of the sperm were moving when
Oh.
they thawed the vial. My question is, we have 2 vials of sperm left. If we do 2 more cycles of IVF and we still have low fertilization rates, should we do another testing to get more sperm, or do you think we should consider moving on to donor sperm? I don't want to keep putting my husband through surgeries just to get more sperm that is low quality. For that, what that's worth, IVF round 2, currently undergoing priming with testosterone patches for 14 days, and my doctor's going to put me on low-dose stem protocol, Clomid, Minipure, Omnitrope, dexamethasone, ganirelix. thanks again for everything you do for women struggling with infertility.
They're pulling out all the stops for those protocols.
Yeah.
Those are heavy duty doses.
Mhm.
And to only get 3 eggs on that, it sounds like there's both egg and sperm issues here.
Mhm.
You know, and I mean, she's only 36, but to only get 3 eggs is concerning, especially with that type of protocol where they're clearly paying attention, they are clearly pushing as hard as they can,
Yeah.
and then you throw the sperm component into it, which if they had to do a test to check viability, that means that the sample that they got was rough.
This might be one of those you want to do it fresh on the day
Yeah.
of retrieval. Like I know logistically that's always hard because you have to have somebody else
Yeah.
driving and everything like that. But I mean, both of you are going through so much that I do think probably a fresh would be a reasonable
Mhm.
intervention for the next cycle. I don't think I
Yeah.
would I don't think I would stimulate 2 more times. I would do a fresh with the next one.
Yeah. Yeah, there's really not a lot that can be done with that number of eggs and the quality of the sperm and having to use pentoxifylline to make the sperm move. That's rough.
Yeah. All right, let's do 1 or 2 more questions, depending on how long they are, and then we'll wrap it up.
All right. This next one's kind of along the lines of what we've been talking about. What is the success rate for IVF using Tessie sperm? Is there any difference between the success of fresh versus frozen sperm? I love your show and it's been helpful to me throughout my process to educate myself on these important issues. Thank you for your time and guidance.
So for fresh versus frozen, there was an abstract at ASRM last year that showed that frozen was actually better, which it was just an abstract. It wasn't a full study, but it was encouraging to see that, mostly because it demonstrates that frozen sperm is not inferior to using fresh sperm. And so
Mhm.
it makes us feel a little bit better when we have to use frozen sperm because of number issues, because of travel issues, location, all of the various things that
Mhm.
contribute to somebody needing frozen sperm. So fresh versus frozen, I think, is not necessarily inherently a problem when you freeze it. I think it's more related to the inherent quality of the sperm prior to the freeze. If you've got really poor quality sperm, then freezing it may not be doing it any favors. But
Yeah.
I think the
Agree.
freezing process as a whole, like we talked about a minute ago, I think it can expose some problems that you
Mhm.
didn't otherwise quite realize that they were there. But I don't know that the freezing process inherently is problematic, particularly when you're doing ICSI and the lab can cherry pick the best looking sperm that pass both the beauty competition and the talent contest.
Did she say why her husband had to have the procedure done in the first place? Like what was the background? Because
No.
sometimes the reason for it can be part of the problem too.
Right. I mean, you're much better off if it's due to an obstructive cause than a non-obstructive cause.
Right.
So that can have some meaningful difference in prognosis as well. All right, let's do one more. Hi, docs. First, just wanted to start off by saying thank you for how much you do. I've been listening to your podcast for a few months now, and I've listened so much about fertility. My husband and I planned to start our trying to conceive journey back in March of this year, but unfortunately was delayed to discovering a uterine polyp. I had surgery to remove the polyp, but couldn't hurt to get my husband a semen analysis done in the meantime. We just got his results and everything looks good except for morphology. His morphology came back as 0 and round cells showed 25%. Is there a way he can improve his morphology so we can try to conceive naturally, or would you suggest going straight to IVF? Thanks.
What do you think, Abby?
I'm still pondering. You answer the question first.
So looking at a high percentage of round cells, whenever you see round cells, the question is, are those immature spermatocytes or are they white blood cells?
That's very important.
So sometimes a sperm culture can be helpful in figuring that out. The data about that is kind of all over the place. Man, I've been on a study kick today.
You are,
It's
man. I'm really
great.
impressed. I'm impressed with all these studies you're quoting, Carrie. I feel lost or left out, I guess I should say.
Hey, we'll take it when I get it. I could not tell you the authors of any of these, but I know I read them all. So with white blood cells, it actually doesn't necessarily have a negative impact on outcomes. That said, we all treat it and we're all trying to optimize anything. And I would much rather you not be harboring some infection. And usually they're just really low grade epididymitis,
type things.
prostatitis, like
Yeah.
mild things. And so, you take a week's worth of antibiotics and clear it up. But that's one potential issue, making sure that the specimen is looked at in a lab that is used to andrology. There is a difference between your big commercial labs and your local IVF labs. Like,
Absolutely.
our andrologists do this all
Every day.
every day. And
Yeah.
if they have any questions, they're going to go over to the embryologist and say, what do you think? And so you've got in any given lab, multiple people who are very used to looking this, whereas a big commercial lab might be an automated machine and there's not really a set of eyeballs that's experienced looking at it. So I would,
But a lot of times we reflex it too. If there's that question, then we reflex it to culture. And lately, I've had a lot of guys that have had positive for kind of minor things, and then positive for some kind of bad things that we've. And usually, actually, I just asked the fertility urologist about this, and he was saying that really he recommends treatment for at least 3 weeks, just because it takes so long, because it's an environment where the sperm really can't get exposed to the antibiotic easily. So, so it's,
Wow, 3 weeks. I've always done 2 weeks because
Yeah,
the blood testes barrier is a lot like the blood brain barrier, and it does
Yeah.
it does take us more
Yeah.
to fight those types of infections. But 3 weeks.
Yeah, a long time. Yeah. So, so certainly, you want to get that checked out, because if there's an infection going on, obviously you want to know that.
Mhm.
Yeah.
All right.
Right, sounds good. So thank you so much for everyone who has joined us today, listening to all of our male fertility questions. Be sure to tune in next week for more, and subscribe, leave us a review in Apple Podcasts and iTunes. We'd love to hear from you. Stop on by for Instagram, Facebook, YouTube, all the places, and say hello.
You can also visit fertilitydocsuncensored.com to submit specific questions you have about infertility. All questions will be answered on the podcast anonymously for our Ask the Doc segment, so don't hold back. We also love episode ideas, so let us know what you're thinking and want to hear.
As always, this podcast is intended for entertainment. It's not a substitute for medical advice from your own physician. All right. We'll see you next time.
Bye,
Bye.
guys.
Bye.
Bye.